Welcome to Blood Cancer Talks. This is a podcast dedicated to hematologic malignancies where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we will recap the latest developments in lymphoma research presented at the recent ASCO, EHA, and ICML Lugano meetings in June. You will quickly see that the theme of many of the abstracts is the use of bispecific antibodies in different combinations and indications. And we're delighted to have a bispecific antibody expert to join us for today's episode, someone I'm lucky to work closely with at Peter MacCallum Cancer Centre, Dr. Adrian Minson. Adrian is a consultant hematologist and a lymphoma clinical trialist, the first author of the recently published coalition trial of Frontline Glofit plus Polar-CHP in the JCO. Adrian, welcome. Thanks for joining us. Please tell us about yourself. Tell us how you became interested in hematology and in lymphoma.
Thank you, Eddie, Raj, and Ashwin for having me on the podcast. Really delighted to be here. Yes, I'm a hematologist in Melbourne, Australia. I did all my training in Australia, and after gaining my fellowship in hematology, did a 4-year fellowship in aggressive lymphoma under the tutelage of Professor Michael Dickinson. And as part of that, clinical PhD, and had the great fortune of being able to write a number of clinical trials, investigator-initiated trials, investigating novel therapies for aggressive lymphomas, including BTK inhibitors and CAR T cells in mantle cell lymphoma, and as Eddie's mentioned, Glofitamab chemotherapy in frontline patients that's just recently been published. So that's my potted history. I don't know how I really got into hematology to begin with, but I think it was just seeing a few really interesting cases as my time as a medical registrar and being seduced by the complexity and the quick advances in hematology that I wanted to be part of.
Great. Thanks for joining us, Adrian. We'll jump straight into the first abstract, the POLARGO trial, which was presented in plenary sessions at both EHA and ICML. And so POLARGO was a randomized phase 3 trial of 255 patients with relapse refractory DLBCL with at least one prior line of treatment who were ineligible for autologous transplant. These patients were randomized to either receive the CD79B antibody drug conjugate Polatuzumab vedotin plus rituximab, gemcitabine, and oxaliplatin, or Ritux plus GemOx every 3 weeks for up to 8 cycles. The primary endpoint of this study was overall survival, and after a median follow-up of about 2 years, the median overall survival was 19.5 months in the POLAR-GemOx group, whereas 12.5 months in the R-GemOx group to make a hazard ratio of 0.6. Similarly, the median PFS was improved from 2.7 to 7.4 months with a hazard ratio of 0.37. So, Adrian, what do you make of the efficacy results in particular of the POLARGO trial, and how do you think they'll influence our practice?
This is a great study, well designed to answer the endpoint, the patient characteristics as expected for this patient group of transplant ineligible, and many of them had high-risk features. So I think this study clearly shows a benefit to the Polatuzumab containing regimen. There's a much higher complete response rate, which is really important, over double the response rate to R-GemOx. And it's fairly convincing for both PFS and OS, in my opinion, much like we've seen in other contexts and other studies against GemOx. So I think this is part of the bigger story about improving on R-GemOx, and we've seen multiple examples of where that can be done. The question really is, where does this fit in to that new landscape? I think we can all appreciate that R-GemOx can be beaten quite convincingly. But now, which regimen are we going to use in practice? And I think that can be something we talk about this today.
Yeah, I think the efficacy results are pretty impressive across the different endpoints for sure. And in terms of safety, there were slightly higher rates of adverse events leading to discontinuation in the Polar arm, and also higher rates of deaths due to adverse events. Were any particular safety signals that stood out to you? How did you interpret the safety data in the POLARGO trial?
I think the most important point when assessing the safety of most of these studies against R-GemOx is to appreciate that people on the experimental arm received more treatment. Patients are coming off R-GemOx quite early for progression, whereas patients on the experimental arm often receive multiple more cycles of therapy because it was working. There is a slightly perverse increase in safety signal against the investigational arm, but that's just because patients were receiving more therapy. They had more chance to develop adverse events, which we know are cumulative with a GemOx backbone. So I think I'm okay with that safety signal in that sense because patients just received more therapy. It does beg the question about whether the GemOx is the ideal partner to a novel therapy. 8 cycles of R-GemOx is toxic. If you do respond and get to those number of cycles, you will inevitably see some of this toxicity. Is there an alternative combination partner for these novel agents? And we'll talk about a few of those today. I think infection and cytopenias and the rates of discontinuation were acceptable given the benefit that we saw in PFS and OS. But the question is this the best regimen out of all of them?
Well, let's talk about another one in that same basket. Over to you, Raj.
Before we go on to the SUNMO trial, I had a quick question given the overall survival signal that we are seeing here. In the control arm, did enough patients get POLA at relapse or post-protocol, given that we know that POLA has efficacy in relapsed refractory DLBCL?
It's one of the problems with all of these studies. The post-protocol therapy is not always entirely clear in the presentations. I think that's always important to know what people get after they fail if they're not getting the experimental agent. Polar BR and other polar combinations in that later line of therapy has fairly low durable responses. I would personally much prefer to use the Polatuzumab in this combination together than save it for a later line of therapy because I don't think it's particularly effective in that setting.
That's helpful. All right, so now we will pivot to the next trial, the SUNMO trial. For the audience, the SUNMO trial was presented by Dr. Westin from MD Anderson. It enrolled 208 patients with relapsed refractory large B-cell lymphoma and at least one prior line of therapy, patients who were ineligible for auto transplant. And they were randomized 2:1 to receive either Mosunetuzumab, a CD20, CD3 bispecific antibody plus Polatuzumab, or Mosun-Pola for 8 3-week cycles, or the control arm being R-GemOx for 8 2-weekly cycles. The dual primary endpoints were objective response rate and progression-free survival, and about 43% of patients had received only one prior line of therapy, with 60% of patients having primary refractory disease. Adrian, what were the top-line results of this study, and how do you view the efficacy and safety from this randomized trial in comparison with the trial that we spoke about before this?
Thanks. I think this is really exciting data because we're now talking about a chemo-light regimen. The only cytotoxic therapy is the payload from the Polatuzumab. And we're seeing similar kind of PFS and overall and complete response rates. In fact, potentially higher than was seen with the Polar R-GemOx. So we had median PFS improved to 11.5 months compared to 3.8 months. The overall response rate was 70% versus 40%, with CR rate of 51% in the experimental arm. And there's a positive trend for overall survival. So I think consistent with the theme we've seen, this is improving upon the previous standard. But it's particularly exciting because it has less chemotherapy, less cytopenias, and the other adverse effects that go along with continuous R-GemOx. So from that perspective, it's very exciting, but one of the concerns with bispecific antibodies is infection, and that's going to be one of the biggest challenges with introducing bispecific antibodies in combinations. It seems to be a theme across all use of bispecific antibodies, this increased risk of infection, both during therapy, but also late infections.
So regarding the infections, just to dig a little bit deeper into the infections, was there a higher rate of infection-related deaths seen with the Mosun-Pola arm compared to the control arm? And what was the rate you had infection in both the arms?
There definitely was a higher rate of serious infections in the Mosun-Pola arm. Grade 3 or higher infections were 21% in Mosun-Pola. However, the rates of infection-related death were not considerably different. There was 5 deaths in the Mosun-Pola arm and 4 deaths from these complications in the GemOx arm. there will be a higher rate of infections requiring treatment, potentially inpatient admission and intravenous antibiotics. In terms of those leading to an increased risk of death, that seems to be, at the moment, fairly equivalent. We're seeing that in the overall survival benefit as a whole with the novel combination. Definitely an issue with bispecific combinations, but if we are improving patients' PFS and OS, and we can manage these infections effectively, I still think they're highly attractive.
Sounds good.
I'll proceed with the next abstract. We have seen a 2-year update to the STARGLO trial, which we have extensively discussed on our 2 previous episodes, which consist of PFS and OS benefit for the GloFit-GemOx arm. So, Adrian, how do you integrate the results from these 3 trials, all comparing novel regimens to R-GemOx in relapsed refractory DLBCL?
So this is a great challenge, and a great challenge to have, because we're now lucky enough to have multiple regimens that appear to be significantly more effective than our previous standard. In my practice, we need access to these drugs, which we don't yet have. But if I was to compare them, it's going to all be about the rates of complications, the deliverability of the regimens, and the ability of patients to withstand things like cytokine release syndrome. In some patients where CRS might be a big challenge, you might choose the POLARGO style approach and use Polatuzumab with R-GemOx. Whereas in patients that can tolerate cytokine release syndrome, live closer to centers to have the increased burden of bispecific antibody therapy and monitoring, you could potentially choose those types of agents. We're probably going to be in a situation that we've been in before, such as in CLL and mantle cell lymphoma, where we've had multiple trials comparing new therapies against the old standard, but not against each other. So it's always going to be hard to know. The patient populations will be different in each of these studies. It's going to be very hard to know how to directly compare them, and we probably never will get studies that directly compare them. So it's going to come down to what's available in your jurisdiction and the patient in front of you and the side effect profiles.
What do you think of R-GemOx as a choice of control arm in these trials?
Well, R-GemOx, I think, is a reasonable control, because it is what we use for this patient population. As imperfect as it is the reality of what we use. R-GemOx is traditionally thought of as a palliative regimen, but it does have a plateau. We've seen that consistently on all of these studies, that there are some long-term responders on R-GemOx. And at least in Australia, that's what we use as our regimen. We don't have access to certain other combinations, such as POLABR and things like that. So I think it's a reasonable standard, but it's no longer the standard that we should be using for future trials. I think now R-GemOx is no longer suitable, and we've got multiple randomized studies showing a better new standard. So I think it's going to be challenging, but the studies that have been performed to date used a good control arm, and that allows us to know they're an improvement, allows us to perform some comparisons between them, because they all use the same control.
Just building on that question, Adrian, there's been some kind of chatter about 2-weekly versus 3-weekly R-GemOx. Do you think that made much of an impact in any of these trials?
I don't think so. I'm not really up with the data on the 2 versus the 3-weekly GemOx. I don't think it made a major material difference. It's interesting that from a practical perspective, depending on which regimen you've got access to, how do you compare a 3-weekly investigational cycle with a 2-weekly standard GemOx? I think it's an interesting question. They could have gone the other way and just left R-GemOx as it is, and you would have had questions about how directly comparable they are. But I don't think it made a huge difference. We saw in all of the trials that the R-GemOx arm, regardless of which regimen was used, looked pretty similar. They were all fairly consistent in terms of overall response and PFS.
Another follow-up is in patients who might be a borderline transplant candidate, but CAR-T eligible, how would you choose between CAR-T and one of these three regimens?
This is the next question for the field, because in a lot of the studies, the PFS curve, particularly with the bispecific combinations, looks eerily similar to that in the ZUMA-7 trial. We're talking about transplant-ineligible older patients, whereas in ZUMA-7 and Transform, we're talking about transplant-eligible younger patients. But the curves look very similar. And so the question really is, are these combinations as effective or close to as effective as CAR T cells? We don't know. That comparison would have to be done. Whether it will be done is unclear, but it does raise the question for these patients on the borderline of fitness that wouldn't have met the criteria for the ZUMA-7 study because they were transplant ineligible. What do we choose? Do we use what we use and extend the evidence from ZUMA-7 to a CAR-T fit patient? Or do we now use this new evidence and use a bispecific combination? I don't have the answer, but I think it's a really interesting question. And it will depend on other aspects like where your patient lives, how close they are to a treatment center. Can they afford to move for the requirements of CAR T cell therapy and monitoring post-CAR T? How at risk are they of ICANS and the associated toxicities of CAR T cells compared to lower rates of neurotoxicity with a bispecific combination? So I think it'll be those kind of additional elements that come into the decision making.
And we're not letting you get off without the hard questions, Adrian. People will be surprised, Len. We did talk about some things other than bispecifics, but I am going to ask you about yet another bispecific trial. We've been very lucky to have so many promising trials, especially in diffuse large B-cell, read out at these meetings. And the next one that piqued my interest is the German and Austrian R-POLARGO study. It was a single-arm study of 80 patients with untreated large B-cell lymphoma, aged over 60 and not eligible for full dose of R-CHOP per the treating physician. And these studies can have a various mix of people, but they had the median age of 80. They had 26% of patients who were ECOG2 who wouldn't make it onto most clinical trials. They did a simplified geriatric assessment showing that 37% of patients were frail, a bit over 50% were unfit, and only 7.5% were fit. These patients had cardiac comorbidities. At least from the data we were presented, as close as you might get to a real-world population that we see, but on a clinical trial, at least that was my read. So tell me what you thought of the population and also the data in this study.
I've been waiting for this data for a number of years since I saw that this was a concept. I'm really excited by it. I think I totally agree. This was a truly elderly, unchemo fit patient population. So I think they've done a good job at capturing that very difficult to capture patient group. And the results, they're early. So at the moment, we're only seeing the end of treatment response rates. We're not seeing the durability of these regimens. But for a chemo light regimen in an elderly, frail patient population, we're seeing complete response rate of 81% at the end of treatment and an overall response rate of 90%. This is pretty remarkable for a non-chemotherapy regimen and is higher than I would expect with a treatment such as R-mini-CHOP. It's hard to dig out exactly what we're expecting from those studies. I did go back and look at the original R-mini-CHOP, and of course, PET wasn't used, so it's always a bit hard to know how many patients were really getting a CR. But
well, yeah, and the patient populations in these studies are so different, and even with what you get on paper, it's hard to know much that represents the patient in front of you. So
yes,
I agree. Cross-trial comparisons in the elderly and an unfit space are even more fraught than they usually are.
Yes. So I think the key thing is going to be durability of this response, but that response rate is very promising for this patient population. I think safety is going to be the key thing. So we've already talked about infection. There wasn't much data presented on that. So that'll be really important to look at. And cytokine release syndrome, how patients in this group will tolerate that less. So strategies to mitigate that is really important. And I like the way that this study introduced a mandatory pre-phase of steroid and then administered the R-Pola first and then the Glofitamab after. We've seen that strategy being applied in other contexts, particularly in the frontline context, such as on the coalition study, but also on Jennifer Crombie's data, that a debulking before administration of the bispecific antibody, particularly in the frontline setting, seems to be really effective at mitigating against cytokine release syndrome. And we saw that here, 12% grade 1 CRS, 16% grade 2. Some more strategies to mitigate the CRS in this group could be used, but I think that's an acceptable rate of cytokine release syndrome.
We don't typically think of bispecific CD20 targeting bispecific antibodies, at least, as causing ICANS, but there were 7 cases reported in the R-Polarglo study. What do you make of that data?
I find the designation of ICANS to be really difficult, and the overlap with delirium and the expected confusion that comes from a fever in a patient over the age of 80, really tricky. That's what we're seeing here. We've got an elderly patient population with lymphoma and potentially some fever and CRS response. And knowing what's truly ICANS is really difficult. I suspect that's what we're seeing, given that we don't really see ICANS in other situations with bispecifics. It's still a relevant issue because we know that delirium has a poor prognosis. If this regimen is inducing a lot of delirium, then that's still an issue, even if it's not truly ICANS.
Very valid explanation. I want to move, you were sort of started to hint at this question of, there was a bit of frontline data presented with bispecifics as well. EPCORE NHL5, which adds Epcoritamab to POLARCHIP, Glofit-R-CHOP in patients with high-risk disease as measured by less than a 2-log reduction in ctDNA after 1 cycle. There was a European study, NP40126, also Glofit-R-CHOP POLARCHIP, a little similar to Coalition. And then the Jen Crombie study, or the Dana-Farber study that Jen Crombie presented of Glofit plus POLARCHIP, all except the high-risk study with overall and complete response rates in the 90%, and in that high-risk study was 87% overall response rate. If you add those 5 studies to the Coalition data, what do you think the kind of, other than the headline result, which most people can take from an overall response rate in the high 90%, what other lessons do you think there are for us from those series of phase 2 trials of frontline bispecifics in DLBCL?
Yeah, so I think the key lesson is that we're seeing consistency across all of these studies, which is really important. There's not one outlier study. We're seeing similar complete and overall response rates across a range of different settings with different bispecific antibodies and different backbones. So I think that's exciting to see. We need the randomized data, of course, but the feeling is that this is quite exciting and has the sense that there will be a benefit to these combinations. What are we learning from the subtle differences between them? I think that's really important. The issue we were talking about before is the rates of cytokine release syndrome. I think the different strategies are really important here for the development long term. With the Epcoritamab program, Epcoritamab has traditionally in the frontline setting been introduced in the first cycle, even on the first day of the chemotherapy treatment. And the rates of cytokine release syndrome on the EPCORE tends to be kind of in that 50 to 60% range, albeit mostly low grade, but still a reasonably high rate of CRS. Whereas in Coalition, in the Dana-Farber data, where there's been either 1 or 2 cycles of chemotherapy before the administration of the bispecific antibody, we're now talking about less than 20% cytokine release syndrome. So I think from a practical perspective, not having to admit half of your patients for a fever is a really important feature. There's also other aspects of logistics. With Glofitamab, it's essentially 1 dose per 3-week cycle, whereas with Epcoritamab, it's still weekly dosing. So there's practical considerations about how often your patient has to come into hospital The data that I've seen have suggested that the toxicity of adding the bispecific in addition to the chemotherapy is very reasonable. Cytokine release syndrome is a new toxicity, but in terms of cytopenias, febrile neutropenia, and all of the key peripheral neuropathy and those key side effects that go along with R-CHOP or polar R-CHP, there doesn't seem to be a huge jump in terms of issues. And most patients are completing therapy on time with few dose reductions and very few patients needing to come off treatment due to associated adverse events. Those are my key takeaways. This is a feasible strategy that is relatively safe and is consistently showing high rates of response and justifies us putting a lot of effort into these phase 3 studies.
Moving on to the next abstract, we have seen the combination of Epcoritamab with RICE. This was a single-arm trial in relapsed refractory DLBCL who received more than one prior line of therapy and are eligible for autotransplant. We have seen EPCORE-RICE for 3 cycles, followed by Epcoritamab until transplant or disease progression. Total of 31 patients were presented in the single-arm trial at the meeting, the median age being around 62. Almost 81% had one prior line of treatment, and 65% progress within 12 months of first line of therapy. That shows that now these are sick patients who have aggressive disease. In the data, they've seen an overall response rate of 87% and a CRR of 65%. Adrian, what do you make of these efficacy data?
This is predominantly a study of second-line treatment in transplant-eligible patients. So in contrast to our previous discussions, that was mainly transplant-ineligible patients. So this is a slightly different study, but a similar concept, adding a bispecific to a standard chemotherapy salvage. And what we're comparing this to in our minds is a number of things. We're comparing it to standard salvage and autograft, but also to second-line CAR T cell therapy, and also to those other regimens we've talked about with lower intensity chemotherapy or non-chemotherapy or chemo-light regimens. So we have to keep all of those things in mind when considering this style of a regimen. I still think that the top-line results are encouraging. We know that in patients treated with standard RICE and autograft, the complete response rate we expect is around 40%. And roughly 35 to 40% of patients actually go on to receive an autologous stem cell transplant. This is probably a higher risk patient population, and most of the patients were within that primary refractory or early relapse. So we know that they do even more poorly than late relapses. So I think this is still encouraging data. 65% of patients got to transplant, nearly double what you'd expect in the standard of care setting. So as a strategy, I think it's successful in doing what it's trying to do, but it raises a number of questions for me. Is the transplant, is this too toxic? Because toxicity is a concern here. Is the transplant necessary? Is the strategy of combining the bispecific with a more intense chemotherapy getting you much more than what we saw with GemOx? So is it enough of a benefit using a more intensive chemotherapy to justify the toxicity? I think those are all the questions. In this study, it was interesting to see that a small group of patients didn't receive the transplant. It's not entirely clear why they didn't get the transplant, whether that was just patient decision. But we see that in those patients that continued Epcoritamab without the transplant, many of those were long responders. So, and we saw a similar thing on 4 of the EPCORE NHL2 study, which was Epcoritamab with DHAX. That study also had a cohort of patients that didn't receive the transplant, and again, quite a number of long responders. So raises the question about whether the transplant is actually required in this setting.
As you briefly touched upon the toxicity, we have seen in this early results that in the treatment emergent adverse events leading to epcoritamab dose delay was about 71%, which is definitely higher. And infections were reported in 58% of the patients in the clinical trial, as well as grade 4 thrombocytopenia in about 58%, grade 4 neutropenia in 84%, and we also seen grade 1 CRS in about 42% of the patient population, and grade 2 in about 10%. So do you think the toxicity of combining epcoritamab with rice is unacceptably high?
So it is high. It does sound very high, but you have to remember that rice alone, you're going to expect significant cytopenias. That's already an expected side effect from that salvage treatment, but it does speak to the feasibility of this strategy. Can you really dose patients on a weekly basis when their counts are rock bottom? Is that a feasible thing to do? It sounds like this study had some rules around that. You had to delay the dose of epcoritamab if you had high-grade cytopenias. Did they need to do that? That's an expected side effect from rice. Some of those treatment delays would have been protocol mandated. Whether they needed to occur is always a question in my mind. Perhaps we just dose through those expected cytopenias. But it does concern me. 58% of patients had infections. That is a significant proportion and higher than I'd expect with rice alone. That's why I'm questioning whether the transplant is truly necessary in these patients, because you've already given them a fairly toxic combination regimen, and then they go into a transplant with all the associated infective complications. So I think this regimen would be most attractive if it obviates the need for the transplant and still gives you a higher curative fraction than in the standard setting. So I think that remains to be seen, but that's where I see this moving, rather than this being with the transplant being a competitor to CAR T cells, because I just think with the toxicity that we're seeing, it's not going to be a good alternative to CAR T cell therapy in the second line.
Maybe this will be the last nail on the coffin of transplant in relapsed lymphoma. All right, so now we'll go to the next abstract, Lotus 7, which is Loncastuximab.
Although before you nail it fully shut, Raj, I should note that there were 6 patients in a PR at the time of their transplant, and 5 of those did deepen to a CR. So yeah, you might have to leave just a tiny little gap in the lid before you nail it all the way down.
And certainly those that got transplant did incredibly well. I totally agree, Eddie.
Especially in places that might not have access to CAR T.
Correct. Exactly. Yeah. Yeah.
All right, so now we'll go to the next trial, which is Lotus 7 of Loncastuximab plus Glofitamab. So a combination of an antibody drug conjugate and a bispecific antibody. Basically, just for the audience, it's 41 patients with relapsed refractory large B-cell lymphoma with 1 or more prior line of treatment, and it combined the anti-CD19 antibody drug conjugate, that's Loncastuximab tesirine, at 2 different dose levels with the CD20 and CD3 bispecific antibody Glofitamab. And now some of the unique caveats about this trial is prior transplant or prior CAR-T were both allowed, but had to be at least 100 days earlier. The trial excluded patients who had clinically significant third space fluid accumulation, as this is a known side effect of Loncastuximab. So patients basically got 8 cycles of Loncastuximab plus Glofitamab, and then 4 further cycles of single agent Glofitamab. The median age was 71 years, 85% had advanced stage disease, about half had 1 prior line of treatment, and the remaining half with 2 or more prior lines of treatment. And interestingly, about 10% had prior ASCT and 20% had prior CAR-T. So, Adrian, what do you make of the tolerability of this combination? Maybe we can talk about the tolerability of the safety profile first, and then go into the efficacy of the combination.
Sure. So I think this is a great trial to talk about. It's early data, but given what we've discussed so far, I think this is good to compare with the SUNMO study of Mosun Pola, similar combination, bispecific plus an antibody drug conjugate. This time Glofitamab instead of Mosunetuzumab, and Loncastuximab versus the Polatuzumab. So just a quick comparison between those two strategies in a similar patient population. This is chemo-light treatment, potentially with a more active bispecific antibody than Mosun in diffuse large B-cell lymphoma. We'll talk about the efficacy in a moment, but in terms of the tolerability, my overall impression was that this was a fairly tolerable combination. There were some treatment discontinuations, but it was less than 10% of patients. So it wasn't a huge number. The effusion-related adverse events of interest, and there were a few of those. That's an interesting component to this regimen that's different to SUNMO. But again, they were relatively infrequent. And CRS was pretty good for Glofitamab. So I think, again, that speaks to that kind of improvement in CRS with the combination therapy. And again, this study introduced the Loncastuximab first and then the Glofitamab a week later. So I think an element of debulking occurred. Perhaps that could be optimized further. Cytokine release syndrome compared to Glofitamab monotherapy appeared to be pretty favorable here.
Now that we've spoken about tolerability of this regimen, can we talk about the top-line efficacy results, especially the complete response rate, and do we have any data on whether these responses were durable?
I think the key reason to include this abstract is the top-line efficacy. It's early data. We don't have long follow-up to know if these are durable, but the complete response rate of 86% and overall response of 93% is pretty enticing. The median duration of response at an early time point had not yet been reached. This is the highest complete response rate we've seen in a roughly similar population. This had half patients in second line and half patients in third line plus. So I think it's exciting data, and we need more patients and longer follow-up to really know. I think they used 2 doses of Loncastuximab, which was an interesting element. The higher dose had lower rates of CRS. So it speaks to that kind of disease control early on before you administer the bispecific. If I was to move the regimen forward, I would pick that higher dose. So I think it's a really attractive strategy.
We had quite the bispecific bonanza there. I just want to reassure people that we did actually talk about something other than bispecifics for brief periods of time during the meeting. One of the themes, I think, particularly of ICML, was around classification of DLBCL. Some clinicians might say, well, we've been trying to subclassify DLBCL for at least 25 years now. Have we finally reached nirvana, Adrian?
As a clinician, I've been watching from the sidelines, essentially waiting for someone to come up with the definitive classification system. I struggle to keep up with the various systems and the differences and the nuances between them. So it certainly feels like we're getting closer. There's a lot of agreement between the various classification systems now, and attempts to simplify, which I think is practically the most important thing. These are complex algorithms that take into account so many different genomic and other factors, and on a practical level, really hard to implement. So I think seeing some of these attempts to simplify the class and online portals where you can essentially input the data and get your classification out, it feels like we're getting much closer to be able to use these in real life. And I don't think we're quite there yet, but I think it's time for me to take notice and work out how we're going to use this in clinical practice.
I also want to recommend anyone who has access to the ICML online content that David Scott's talk I thought was really excellent, because I think he simplifies the translational stuff enough for us humble clinicians to understand. So certainly commend anyone who hasn't watched that talk to watch it. I agree. It feels like we're getting closer. Clinicians should probably wake up and start taking closer notice. The last bucket of abstracts I wanted to ask you about, Adrian, the ICML organizers did a lovely job, I thought, of putting these 4 abstracts back to back, which was that there are 4 CD19, CD20 targeting CAR T products. They all target them in slightly different ways. One has a logic gated, it's quite cool to see the different approaches to trying to improve upon our current CAR T regimens. One of the question is, what did you make of them? But I think it's very hard to compare the clinical data at this stage. But really, the question I'm more interested in is, where do you think we're headed? Are these all products going to all try and land in the post, currently approved post Axiom and Lysocell third line plus setting? Where do you think we're heading with these novel CAR T products?
I don't know, because what problem are we trying to solve with these bispecific CAR T or these dual targeting CAR T? To my mind, the main thing that we're trying to address is the antigen loss. So losing CD19 as a mechanism of escape. And in contrast to ALL and other settings, it doesn't seem to be the predominant resistance mechanism in diffuse large B-cell lymphoma, at least. So it does occur, but I'm not certain that just adding another target is going to dramatically improve the durable response rates. I think there probably will be some improvement, but not necessarily a huge leap forward with this. There's also problems targeting CD20 early on. If this becomes the standard second line treatment, then we potentially have lost bispecific antibodies targeting CD20 as an effective treatment later. Or if bispecific antibodies become frontline, then 20 might be lost at relapse, and therefore the second target of these CAR T cells may be rendered useless. It's hard to know where this will land. I think it's really interesting to see, as you said, the differences between them. Only very little data was presented of post CD19 CAR T with these. There seemed to be some responses, but it wasn't easy to identify how many patients responded after receiving a previous CAR T. That'll be really important information. And then there were differences in the way that they were manufactured. There was one product that was a kind of a rapid manufacture bench side, which was interesting from that perspective, just because it was such a fresh product. I'm not sure, Eddie. I think it's great to see people innovating the CAR T. The current ones we have are great, but imperfect, and they can always be improved upon.
Yeah, are we going to end up with a CAR T that's really rapidly manufactured, or one that's got better efficacy, or one that's got less toxicity, or some combination of the three? It's certainly good to have fertile ground with lots of new kids on the block. Thank you for joining us for our lymphoma conference roundup and taking time to speak with us, Adrian, and we'd love to have you back in future at some point.
Thank you for having me. It's been a pleasure.